All right, let's jump straight in. We're running an integrative mixed block simulation today, focusing entirely on high-stakes gastrointestinal emergencies. There's literally no room for hesitation here. We're going to break down the precise pathophysiology, the absolute diagnostic mandates, and those lethal management traps of ischemic and inflammatory bowel catastrophes. Let's go. Module 1, Acute Mesenteric Ischemia and Embolic Kinetics. The absolutely crucial point here is the sheer profundity of the ischemia. We're talking about an abrupt, massive interruption of blood supply to the intestines, and it's typically driven by an acute thromboembolic event. You'll classically see this clot lodge right in the superior mesenteric artery, or SMA. When that happens, it abruptly chokes off blood flow to the jejunum, the ileum, and the right colon. This isn't something you can sit on. It's an immediate surgical emergency. Now, the pathognomonic presentation is something you just have to hardwire into your diagnostic repertoire. The absolute clinical hallmark here, severe, unrelenting abdominal pain that is completely, and I mean completely, out of proportion to what you find on a physical exam. Especially early on, you'll see a patient who might be literally screaming in agony, but you feel their abdomen and it remains surprisingly soft. You won't see those overt peritoneal signs like guarding or rigidity right away. It's a massive red flag. So, as this occlusion persists, we start to see a very distinct biochemical signature. The ischemic bowel is basically forced to shift rapidly from aerobic to anaerobic metabolism. And what does that do? It drives a profound high anion gap metabolic acidosis. Your key serum marker to watch for here is a rapidly elevating lactic acid. We're frequently seeing it surge above 6.0 millimoles per liter. When you see that number, you know severe tissue necrosis is actively underway.
Okay, let's look at the strict diagnostic and surgical sequence. CT angiography of the abdomen? That's your gold standard. However, you've got to watch out for this critical clinical trap. If your patient develops overt peritoneal signs, like a totally rigid abdomen, that means the bowel has already infarcted. At that point, the absolute mandate is to bypass all imaging. You don't wait for a CT. You proceed directly to an emergent exploratory laparotomy to resect the dead bowel.
Let's isolate the diverging variables in these presentations. Acute mesenteric ischemia usually falls into two camps, embolic or thrombotic. An embolic event is highly acute, and it typically originates from a cardiac source. Your classic board presentations are going to feature a patient with untreated atrial fibrillation. Conversely, a thrombotic event, that's acute on chronic. These patients already have severe pre-existing atherosclerosis. They'll usually give you a history of intestinal angina, that postprandial pain and severe food fear that leads to significant weight loss. All right, time for our first integrated assessment. Picture this: a patient with a known history of atrial fibrillation develops sudden, agonizing abdominal pain. But on palpation, their abdomen is remarkably soft. Labs come back, and you've got a lactate of 6.2. You need to rapidly synthesize this clinical hallmark and those biochemical markers. Given all this, what is the strictly mandated diagnostic step? Let's break down the options. The correct answer is CT angiography. It's the absolute gold standard for diagnosing an acute SMA occlusion. But let's analyze the traps and the distractors. Colonoscopy? That's incorrect. It's actually contraindicated because it risks perforation and critically delays surgical triage. Mesenteric duplex ultrasound is also incorrect. Why? Because visualization of the acute vascular state is just suboptimal. It's usually obscured by bowel gas. What about diagnostic peritoneal lavage? Totally obsolete for this highly specific vascular presentation. Finally, exploratory laparotomy is incorrect here because without overt peritoneum indicating infarction, rushing to an open abdomen is premature. A CTA can guide a targeted endovascular or surgical revascularization first. Module 2, ischemic colitis and watershed hypoperfusion. We're shifting our focus strictly to the large bowel now. Looking at the source vignette here, we see the exact mechanism of insufficient blood flow and oxygen delivery, specifically targeting the watershed areas of the intestine. These are regions at the very far edges of vascular territories. The most notable ones being the splenic flexure, which we call Griffith's point, and the rectosigmoid junction, known as Sudeck's point. Because of their location, they're the absolute most vulnerable spots to drops in systemic perfusion. Let's contrast the hemodynamic profiles directly. That SMA ischemia we just covered, that's a large vessel occlusion, a literal physical blockage, like a thromboembolism. Ischemic colitis, on the other hand, is strictly a low-flow state.
It's a profound hypoperfusion injury that happens directly because of a systemic hemodynamic drop. It's a completely different mechanism. So how does this build out our clinical differentiators? Well, ischemic colitis classically follows an episode of severe systemic hypotension. Think about massive hemorrhage, cardiogenic shock, or even a heavy hemodialysis session. Because of this, the symptom profile shifts entirely. Instead of that agonizing out-of-proportion pain, you're going to see mild to moderate crampy abdominal pain. And this is rapidly followed by bright red hematochezia, or bloody diarrhea.
The management mandate here is predominantly supportive. You want to immediately initiate intravenous fluids to correct that hypoperfusion, enforce bowel rest, and get them on broad-spectrum antibiotics. Now, a colonoscopy is diagnostic. It'll show this pale, edematous mucosa with petechial bleeding. But listen closely. You absolutely must defer a colonoscopy if there is any clinical or radiographic suspicion of bowel perforation. That is a strict rule. Let's lock this in by directly comparing small versus large bowel ischemia. Small bowel SMA ischemia, that gives you severe pain, no initial bleeding, a massive lactate spike, and it's triggered by a clot or AFib. Large bowel ischemic colitis, though, that gives you mild to moderate crampy pain, rapid bright red bloody diarrhea, a relatively normal lactate, and it's strictly triggered by a preceding episode of systemic hypotension. Know these differences inside and out. Here's your next integrated assessment. An elderly patient is recovering from a ruptured abdominal aortic aneurysm repair. On postoperative day 2, they suddenly develop left lower quadrant pain and a rapid onset of bloody diarrhea. You need to isolate the watershed hypoperfusion occurring strictly post-systemic hypotension. So what is the most likely diagnosis? Let's break down the 5 options. Ischemic colitis is unequivocally correct here. The ruptured AAA and the subsequent surgery dictate a massive hypotensive shock event that leads directly to a watershed injury in the left colon. Angiodysplasia is incorrect. Sure, it causes bleeding in the elderly, but it completely lacks that acute hemodynamic shock trigger. Diverticulitis is incorrect. It presents with LLQ pain and fever, but it typically doesn't cause profuse, rapid bloody diarrhea. Cytomegalovirus proctitis? Incorrect. That strictly requires a severely immunocompromised state. And E. coli 0157H7 is also incorrect. That's an infectious etiology that is completely unrelated to the isolated variable of a massive AAA repair. Module 3, toxic megacolon and smooth muscle paralysis. Now we're pivoting away from pure vascular insufficiency and diving headfirst into severe, fulminant inflammatory cascades. First, we've got to establish the pathophysiologic trigger. Toxic megacolon is an acutely catastrophic bowel complication. It is driven by profound mucosal inflammation, and it almost always precipitates from either a severe clostridioideal infection or a highly fulminant ulcerative colitis flare. The intricate cellular mechanism behind this is actually fascinating. Massive mucosal inflammation triggers local mediators, primarily a massive release of nitric oxide. This nitric oxide surge induces a state of neuromuscular blockade, literally paralyzing the colonic smooth muscle. And without that muscle tone, the colon just begins to massively and rapidly dilate. The diagnostic triad for this is very strict. First, the patient is going to appear intensely toxic. We're talking high fever, severe tachycardia, and often an altered mental status. Second, the diagnosis absolutely requires an abdominal plain film that demonstrates colonic dilation exceeding 6 centimeters. You'll also often see a loss of haustral markings, notably right in the transverse colon. And that brings us to a frankly lethal pharmacological trap. It is an absolute contraindication to administer anti-motility agents like loperamide or opioids or anticholinergics to a patient experiencing a severe colitis flare. Do not do it. These agents further suppress bowel motility and will directly and aggressively precipitate a fatal toxic megacolon. Here is your final high-stakes assessment. A known ulcerative colitis patient arrives with a grossly distended tympanic abdomen and a temperature of 103 Fahrenheit. An abdominal X-ray reveals a 7.5 centimeter transverse colon. You've got to navigate the pharmacological traps here and determine the absolutely mandated intervention. Let's evaluate the options. Intravenous corticosteroids is strictly mandated here, so that's your correct answer. This patient is in a fulminant ulcerative colitis flare complicated by toxic megacolon. They need IV steroids immediately to suppress that catastrophic inflammatory cascade. Oral loperamide is wildly incorrect. Like we just established, that is an absolute contraindication that practically guarantees fatal dilation. A barium enema is incorrect because there's a severe, immediate risk of precipitating an acute perforation of that paralyzed, thinned-out bowel wall. Complete colonoscopy? Incorrect. Introducing Aaron's scopes into a 7.5 centimeter dilated, inflamed colon is strictly contraindicated. And finally, oral vancomycin is incorrect. While it's great for treating C. diff, it does absolutely nothing to treat the underlying primary ulcerative colitis flare that's driving this specific scenario. Intravenous corticosteroids is the exact necessary answer. And that concludes our simulation.